So I think that, when you go back to this prostate cancer disease continuum slide, again, the urology community has been very, very active in the institution of hormonal therapy. But as I referenced before, that ultimately these patients will fail. And once again, as this slide indicates, is that really the next phase for many of these patients, historically in the past, the only thing that urologists used to give was some element of second-line hormonal therapy, which usually was either the institution of bicalutamide or the withdrawal of bicalutamide. The problem with that is that really all we were doing at that point is not really changing the survival of these patients. Really what we were doing was just changing PSA kinetics. So the next form of therapy that was approved is actually sipuleucel-T or Provenge. And this is a therapeutic vaccine specifically made for each patient, and this was FDA approved in April of 2010 for the treatment of asymptomatic or minimally symptomatic patients with castration-resistant prostate cancer, basically a field that we now call CRPC-M1 disease. So, Bryan, I know you've got a very active interest in this field. Can you talk to the audience a little bit about how sipuleucel-T works, how it's manufactured, and how you are currently using it within your practice?
So this is a very patient-specific treatment. Patients will go to an apheresis center and have their blood filtered, a bag of white blood cells collected. That will go to the manufacturing facility where it is incubated, activated. There's all kinds of technical aspects of how that is created. But eventually, 3 days later, that'll come back to our office and we do a 1-hour IV infusion of these now activated white blood cells that have been trained to attack the patient's prostate cancer. In our office, it's been a fairly straightforward process of establishing IV access, IV infusion. Patients are pre-medicated with Tylenol and Benadryl. They can have fevers, chills. It is an immune product, so in some ways it's kind of like giving BCG bladder installation, some of the same prodromal or flu-like symptoms that are fairly easily managed in our office. Patients spend an hour, hour and a half in the office and go home.
So we hear this all the time because as urologists, we are classically trained surgeons, and I have partners and colleagues that will say, well, I don't want to give chemotherapy. I'm not trained to give chemotherapy. Why should I do this? These patients will get really sick, right? And plus, this is a fairly difficult process.
Yeah, I think, in our office we never gave Zometa IV infusions. We just didn't want to get into the whole IV access. So I understand that. It is, having someone who's qualified to put in a reasonable IV. So that was a hurdle for my staff. There was a lot of, I think, built up paranoia about the infusion. What ifs of what could happen. Even one of my partners wanted to know, well, I'm on call, what do I need to know when the patient gets admitted? When really only about 1.2% of patients in the clinical trial ever got admitted related to their infusion. So I think at first we were all geared up and ready for anything that could happen, and now, and it was all run through me and my clinic, and very controlled situation, and now I think everybody's got that comfort level going. There's infusions being done in my office now that nobody even tells me about, so I think it's gotten to the point that it seems fairly routine. And if you believe in the science that this is going to help somebody live longer, I think it's totally appropriate for a urology office to be involved in that.
Dan, your experience in San Antonio, and also talk a little bit about, number one, your view on the role and the indication of sipuleucel-T in terms of what's recommended by NCCN, and also what is the benefit? What does the data suggest about survival benefit on patients who receive Provenge?
The studies that were done, and the definitive study, like you said, in April of 2010, showed that there's an overall survival advantage of about 4.1 months for patients who've received Sipuleucel-T. What the NCCN guidelines currently state that this is the first line, or give it a Category 1 recommendation, to use Sipuleucel-T in patients who are asymptomatic or minimally symptomatic with metastatic prostate cancer that are castrate-resistant. We have incorporated that into our office. We've probably done over 18 patients infusions. I will reiterate what Bryan said. We had the same experience in our office. There was a lot of apprehension at first, but I think as the docs have figured out how user-friendly this really is, that it has not been, the hurdles were easy to overcome. I think in the 18 patients I've treated, I've had to, I've gotten 1 or 2 phone calls on the day after a second infusion for a low-grade fever, and that's been about it. But it's been very straightforward and easy to institute into your urological office. We had done a lot of clinical research in the past. We were on the trials, number 1. Number 2, we had also done the Zometa trials. And so we were very comfortable doing IV infusions. We had the setup. It didn't take a lot of capital expenditure to do. We have a nurse that's very comfortable with that in our office at this point in time.